to The Real Project. This is our second Wednesday night, and we're glad that you've come and joined us tonight. And just by way of introduction, my name is John. I am the senior pastor here, and the other young guy at the front desk out there is Anthony, and he's the assistant. And we just want to welcome you on behalf of our church here. People have asked us, why are you doing this? And it's very simple. We have a philosophy that we believe that the church exists to help the local community. And so last week we gave away free massages on Wednesday night. If you missed it, you're too late. But some people here had a wonderful time, and they went away without any stress in their life. And so tonight, of course, we have the forum on depression. And next Wednesday night, we have a special program. We have a couple of local artists who are going to be here, and it's a paint night. And so if you're into painting, we have a special project that we do here with a community agency. And what we do is we partner with them, and we paint ceiling tiles. And those ceiling tiles are painted, and we donate them, if you wish, or you can keep yours, but we donate them to the nursing homes in and around the city, and they are placed in the ceiling above a patient who is bedridden so that they have something nice to look at. And so there's no cost for this program. If you are interested in coming and painting next week on Wednesday night, this is a wonderful opportunity for you. You can keep your painting or you can donate it and have some fun with it. All of the materials are supplied, all the paint, the brushes, the tiles, everything is all provided for you, and there might even be some sweets available as well so that you can, hit that sweet tooth while you're painting, because there's a lot of hard work, right? And we don't want you malnourished while you're doing it. So it's meant to be a relaxing time. So good to have you tonight. Tonight's program is one that when we sat and we dreamt about what we wanted to do this year to make a difference in our community, that was one of the first things that we identified. Is having a program on depression. As a pastor, a professional in the community, this is something that we run into time and time and time again. It is a significant issue within our community. It is a significant issue even in my own family. I have a brother who went through a messy separation and now divorce, and for the longest period of time, and still is, we've got that concern that he might do something stupid because he has really taken a nosedive down into depression, and we've been working hard with him. In fact, last year I spent almost a whole month with him, building a garage with him, occupying his mind, just so that we could keep him from doing anything stupid. So I understand what depression is all about. I've dabbled with it a little bit earlier in my college career, but not since I've come out of college. Been having too much fun ever since then. Our guest tonight is an expert in this area. He is Dr. Pratap Chokka. He doesn't know this, but my wife informed me today that she actually went to school with you many, many years ago, back in, I guess it was the 80s, early 80s at CUC, I believe it was, or somewhere in that area. Anyway, she says that she's got a picture of you in a yearbook somewhere. So I said, wow. Anyway, Dr. Chokka is well known in the city of Edmonton for the Chokka Center. And it's world renowned. He is an expert in the field. This is my first time meeting him, but I have utilized his services. He doesn't know this, but I've made some referrals. And so I believe in the work that he does. I believe that God has gifted him in a very special way. And when we were planning this program, this is the individual we targeted. We wanted to bring in what we viewed as the very best in the city of Edmonton to be able to come and talk to us and share with us. And so tonight, Dr. Chokka, is an honor to have you with us. And we appreciate so much you taking of your busy schedule. And believe me, I know how busy you are. Trying to get a hold of you is any indication. So thank you for coming tonight. And let's bow our heads and pray. And then the next voice you'll hear will be Dr. Chokka's. Father, as we come into this house of worship tonight, we're here because we want to learn. We want to understand. We want to be able to know what the issues are as it relates to depression. So many of us have struggled with depression. So many of us have family members who are struggling. And we want to know what we can do and how we can help. And so as Dr. Chokka shares with us this evening, my goal and my prayer, Lord, that he would speak to us and that he might enlighten us so that when we leave here, we'll be much better educated on this subject than what we were when we came in. We ask these blessings now in Christ's name. Amen.
Amen.
Dr. Chokka.
Thank you. Wow, that was an amazing introduction, Pastor Murley. I'm not sure if I can live up to those compliments, but I really am honored to be here tonight. I think what the South Church is doing is quite remarkable in trying to reach out to individuals in our community and to get real about issues that we all face, And just a little bit of a background on myself. Born in India, you probably couldn't tell, but raised in Alberta, good old Albertan, and small town called Vegreville, Alberta. You ever heard of that? Yeah. I mean, my last name is Chokka, but it actually was Chokka, and I had to kind of cut it off but that was my Ukrainian influence, and then eventually made my way and went to school in southern Alberta, Lacombe, and I was fortunate enough to do medicine at the University of Alberta. And when I graduated, there was a bunch of areas of specialty that I was interested in, and I think psychiatry found me as opposed to me going into psychiatry, because I think when you're in your mid-20s and deciding for a career, you're not quite sure what you want to do, but it's been an amazing journey for me to be a psychiatrist, mainly because I think my patients have taught me so much about the kind of topic that we're going to talk about tonight, and it's made me really realize that there's not much difference between physician and patients. There's a very fine line. And so the topic we're going to talk about today is not something that is foreign to any one of us. In fact, I want you to, by a show of hand, tell me, is there anybody in this room that does not have anybody that they know that doesn't suffer from depression? Put your hand up. "25 or 30 years ago, I'm not sure if the same response would have happened. I mean, these illnesses are things that are common to being human. And in my 25 years as being a physician, I've realized that we've come some ways in trying to look at mental illness, but we have a long way to go. And I think sometimes the stigma, especially for individuals who are Christians or faith-believing, I think is even more sometimes. Because if you're a faith believer, you're not supposed to have mental illness because God will work it all out. And there's a lot of stigma that comes from being a Christian or believer in faith and struggling with mental illness. What I want to do today is really talk about a condition that is so common that everybody in this room is familiar with it in one form or another. There's a lot of things I could have talked about, but I've really distilled it into about 10 or 12 slides. I really would like to have conversation this evening with all of you, instead of showing you data and information. And I hope that at the end of the next, half an hour, 45 minutes, we've had a good, lively discussion, and there's some pearls that you'll go home with. I want us to also have a good time tonight. Even though we're talking about depression, I don't want us to feel depressed about it. I want to leave you with words of encouragement and hope, because I think that's what we can do in dealing with this illness. So you guys ready for this? All right. So depression, what really matters. I'll start with some sobering stuff. This is the leading cause of disability on the planet. Were you aware of that? Ahead of cardiovascular disease, ahead of infectious diseases, and so on. So the World Health Organization has determined that depression causes more disability globally than the other illnesses which we're very familiar with. And we're noticing that as the world has gotten more flatter economically, that when the basic needs have been met, that mental illness, and especially depression, seems to rob individuals of joy, relationships, academic success, occupational success. And World Health economists are really saying that this is a huge problem, not only for individuals, but globally. The leading cause of disability in the world. Does that surprise you? Yeah, I think for the average person, and in my community of physicians, I think we get caught up with the more common conditions, stroke, heart disease, cancers, and we think, yeah, those are the leading causes of disability. No, this is the leading cause of disability. And by 2020, this is the projection of it around the globe. I've had the fortune of being able to travel in different parts of the world, and you would think that depression was a North American phenomena, that it's a disease of affluence and we've got everything, so we're going to be depressed about things. And that's not true. And even developing countries, we're finding that depression is a very common and disabling issue. This isn't just a disease of North America or of developed countries. It's all over the planet. And I think that's important because one of the points I want to establish right at the beginning is that depression is a medical disorder. And I think it's unfortunate at times that we use words like depression because routinely we throw words like, well, I'm depressed. You know, I've had a tough day, I feel depressed, I'm going through some depressing times. It's different than somebody who says, you know, I've got chest pain or my leg's broken. You know, we can understand that in a different way. But the word is there, it's in the medical jargon, but I think we sometimes use it in a way that isn't meant to be used. I'm talking about this as a clinical medical entity, and I'll show you some science behind it and the approaches that we're now trying to take, because it's not as simple as I thought when I was a naive young medical student graduating, I know, almost 30 years ago. But here are some facts. So number one, it's the leading cause of disability in the world. It is one of the more common medical disorders. And depending on the study, about 1 in 10 of us will be affected in our lifetime by this condition. So it's fairly common. And unfortunately, there is some differences in sex in terms of who's more risk. We know that women, ladies, unfortunately, you're more at risk for this than men are. About 2 to 1. Okay? And this is one of the more common, robust findings, is that it's more common in women than men. And there's many factors, and we can talk about that. We also know that, and I'll show you some evidence, that this is a brain disorder. That this isn't just a weakness of character or of faith, but it is something that is rooted in brain biology. But as I'm going to show you, we are not just chemistry. We're just not an anatomical warehouse. And various factors will impinge on the brain to impact this. And it's a collision and a coming together of nature and nurture. But one of the things I think it's really important is that when you're dealing with individuals with depression, to legitimize it as a medical disorder, as opposed to a character weakness, as opposed to something about the past only, or the way they can't handle things. And I think it allows one to sort of accept that this is something that is rooted maybe is rooted in medicine. The other thing is, retrospectively, the majority of my patients will say, I didn't know what I had until you told me now, but looking back, I remember feeling like this as a kid. 75% of all mental illness is present before the age of 20. Mental illness and depression are disorders of childhood and adolescence. And it has its seeds in that age group. Most people will tell me that. And that's really important because one of the problems we're having is from the time that somebody suffers the symptoms of depression to the time that they get help, there's a lag period. So let me ask you, how long do you think the average individual with depression will take to recognize it to be an illness and come and get help? Sorry? Speak up.
I think some never recognize it.
Right? Put it on an average.
On average, I would say probably maybe 4 to 5 years.
Okay, others?
I would say 20.
20?
I would say in general, when it end up in a big issue, then we think of.
Then you'll think about it. Yeah. The lady there is the closest. It's about 4 to 5 years. So imagine having a pneumonia for 4 to 5 years. And we know the problem in delaying diagnosis and treatment is that it changes not only the brain, but it affects the way that we perceive the world when depression goes untreated. And we know that it's really important to recognize it early because early treatment portends a better outcome. We also know that depression runs in families. It's not a pure genetic risk. In other words, you can't predict it 100% of the time. But we know that if somebody in your family, especially what we call your first-degree relatives, okay, you're more likely to get it by a factor of 3 to 6 times. So for example, what does that mean? If the lifetime prevalence of depression in the world is 10%, and let's just say your mom or dad had depression, your risk goes up by a factor of 3, 30%, or even 60%. So that's really important. So one of the things that I want you to know is ask some of your family members, they may be now more able to talk about it, you know, does your mom have it? Does your dad have it? Did grandpa have it? Did grandma have it? Because we know it runs in families. So we know that there's a genetic component to it. We know that it starts very early in childhood. When I say childhood, it's more adolescent, probably around 15 to 16. The problem is we often mix up childhood and teenage angst and turmoil of just growing up. And we get, I guess, kind of blinded to the fact that there could be a serious mental disorder going on. And that's where I'm going to get into in terms of talking about what are the things to look for. All right? We also know this, and this is something that's so important, is that although depression is a brain disorder, there's compelling evidence that people with depression are much more sicker physically. What happens in the brain affects your body. And one of the problems, I think, in contemporary medicine is that we go to our family physicians with physical ailments because we're better at detecting physical ailments. We have better tests and so on. But we know that people with depression are much more likely to have heart problems, hypertension, thyroid problems, twice as likely to have diabetes, suffer from obesity, suffer from other metabolic problems. And one of the things that we're trying to really appreciate to our young doctors is don't separate the mind, the brain, and the body. We often do that as physicians because that's the way we were taught. But depression is a physical disorder and a mental disorder. And we know that if you have depression and, let's say, a heart attack, and the depression is untreated, we know that you're more likely to die within the first 6 months of a heart attack. They did this study. It's a remarkable study. They looked at people who came into the intensive care unit. You had just suffered a heart attack. And we know that the first several weeks, up to 3 to 6 months, is the highest risk for having a second heart attack. When your muscle of the heart gets weak, you're susceptible to another one. And they did this study. It was actually a Made in Canada study in Ottawa, it blew away our ideas of how the mind and the body were working. What they found was that men, especially, who had a heart attack and developed depression either before or after, but were untreated, were more likely to die by a factor of 4. 4 times more likely to die within the first 6 months if their depression wasn't treated. And depression became an independent factor for survival because they thought, well, maybe it's people had heart attacks or smoking and their blood pressure was bad and so on. No. Irrespective of how bad the heart attack was, or if they had other medical problems, depression was an independent factor for poor outcome. And these kind of studies have been replicated time and time again. So if you go into surgery and you develop a depression, you're more likely to have complications after surgery if your depression isn't treated. You're more likely to have problems with strokes and so on. And so treating the mental health aspect is so important to the physical. And I think that is something that's really important for those that suffer from chronic medical illnesses. Most of the problems in healthcare are chronic diseases that are probably very preventable. And we talk about smoking and eating and exercise and all that. We don't often talk about prevention from a mental health point of view, but this is so important, especially for our young children. All right? Because this is a nasty illness that kills people. It kills people every day. Alberta, our Aboriginal community, the highest suicide risk and death is our 18 to 19-year-old kids. In Alberta, we have the highest suicide rate among Canada amongst young Aboriginal teenagers. It's something that we can do something about. What do you think the second highest risk group is for suicide with depression, besides teenagers? Yeah? No. Except you, John. Other groups. So there's the professions. I think I'm thinking more broadly. So we talked about teenagers, but without giving it to you, what other age group? Well, what age group? The second highest risk is the single white male in their 70s. So you've got the teenage suicide, and then you've got the elderly. And now that I'm into my 50s, that elderly term doesn't really make me feel good. Although I think I'm close to getting a little discount at Humpty's, for their breakfast special. But people are dying of this disease, either directly through suicide or secondary to medical problems. We know that people with mental illness and depression die earlier than age comparison because they're more likely to have accumulated very bad habits, drinking, not eating properly, not exercising. They're much more prone to have other medical comorbidities. So it's not a very good thing if you have this illness because it affects you holistically, both mental and physical. So those are some of the facts of depression. All right? Any questions about the facts? Is there anything else that you want to bring out about what you've heard about depression and the facts before I move on? No? Yes?
You mentioned brain disorder. You also mentioned some medical condition. And I would like to know if there cannot be environmental condition like
Right. So did everybody hear the question? Yeah, so it was a great question, which is, doctor, you've talked about it as being a brain disorder. You talked it about as being a disease of young people, a medical condition. Are there other factors such as environment? And you know what? I'm going to get to that. It's a great question. And I've got a slide to address that. If you can just wait for a few minutes, okay? I want to talk about what depression actually is. This is really important. And this is the way that we as physicians diagnose depression. All right? And it's, there's the King James Holy Bible that you guys all refer to every week. Well, we have our own Bible in psychiatry. It's called the DSM. Have you heard of this? The Diagnostic and Statistical Manual, and there's now been 5 versions of it. The first version came out in the 1950s, and now we've gone through different iterations because we're trying to figure out what mental illness is. And so all kinds of researchers sit around tables, conferences, looking at data. What's depression? And we're still struggling with this. This is what contemporary science talks about depression. We don't yet have a blood test. So a lot of it is presentation of symptoms. And the 2 core symptoms are a depressed mood and or a loss of interest or pleasure. And then you've got a collection of other symptoms, including appetite changes, energy changes, feeling quite slowed down or agitated, irritable, sleep changes, problems with self-esteem or guilt, poor concentration, and thoughts of suicide or death. Now I know you're saying, boy, that's me on a typical day, right? I get this every day. What are you talking about, depression? Well, I've been depressed all my life then. Here's some of the other criteria. We need to have it consecutively for at least 2 weeks. Doesn't seem like a lot, does it? Doesn't seem like a lot. So it's 2 weeks consecutively. The key also is the impact of feeling like this on your day-to-day functioning. And so you would think we all have had this kind of problem. But surprisingly, 90% of the planet doesn't. It just seems like we all have it. All right, I showed you the lifetime prevalence. So it's 2 weeks consecutively of a depressed mood. It's not just a sad day, but it's a real feeling of overwhelming blue. And you don't have the interest in things that normally would bring you pleasure. You know, I would normally just love to go to the book club and enjoy my time with my girlfriends and socialize. I just don't have that interest anymore. You know, I love playing hockey, but I haven't been to the rink. Just don't enjoy it anymore. Why is that? I don't know. I just don't seem like it's something of pleasure. One of the big things for you to be aware of is sleep changes. 90% of the time when you have chronic sleep problems, it's a mental disorder that's usually causing it. People with depression often have either troubles getting to sleep, staying asleep, or getting up really early in the morning before they need to get up. And this is one of the most common signs of depression. So if there's been sleep changes in your health, this is something to consider as being serious, especially if it goes on for several weeks. Changes in appetite. Food doesn't taste that good to me anymore. I used to love my pasta. I love Italian sauce. Doesn't change. You could have associated weight changes with that. Sometimes the appetite goes up. Sometimes your weight goes up with this. You feel tired, lethargic. You feel a heaviness to your body and limbs, like if you're carrying a piano on your back. You then begin to also, and this is the nasty part of depression, because there's lies that your brain starts telling about you, what's happening in your life, and about others. And we know this from tests that the front part of our brain that sort of makes sense of us, our environment, starts to go a little fuzzy. And you begin to look at the world very blue. And you begin to look at things that you normally would look at in a positive way in a very negative way. And there's a medical term I call it, and it's called stinkin' thinking. That's what happens when you're depressed. You don't look at things properly. It's almost like a psychotic delusion. We know this. In fact, if you were clinically depressed and I stuck you into a magnetic resonance imaging, an MRI, and I could stick some dye into you so I can see how blood flow is going through, and I showed a bunch of faces to you, this is what they do. This is really cool. So you could look at me and I could be smiling, and if you weren't depressed, you'd say that's a smiling face. Or I could look angry and you could say that's an angry face. We know that in depression, facial recognition is impaired. Reading the emotions of others is impaired. We know that. And when you begin to look at how your vision is impaired, then you know your thoughts are going to be impaired because in some way there's something conspiratory going on. And that's why people say, because you can tell them all the good advice you want, right? You shouldn't be thinking about this. You got grandkids. Look at the Oilers are in the playoffs. They're going to go to the Cup. Everything's going to be good. I don't see it that way. And depression really is a problem in terms of thinking. And that's really important when we're going to talk about treatment. The other thing is prolonged depression, prolonged negative thinking makes you look at the world extremely differently. You begin to lose hope. You begin to lose this idea that life is worth living because every day is a drudgery for you. Like, why would you want to live like this? I've lost some of my heroes, doctors and mentors who taught me in medical school to this disease. I've lost really good friends to this illness. And it kind of shakes you to the core because you think you could have done something differently. But I still can't, after all these years, put myself in my patient's brain because I can't imagine how oppressive that must be that you want to end your life. That death actually is a welcome. But that's the way they start thinking and talking, you guys. And that's a part of depression. One of the things we're also knowing is that when you look at all of these symptoms, it's more complicated than this. We used to think depression was one condition. But what we're actually beginning to look at is that there's what we call depressions. This is what we call a syndrome. It isn't one entity. And we've now found that there's probably over 227 combinations of symptoms that patients can come into experiencing. And I think this is why patients don't know what's going on. And when you go and see doctors in primary care, they're challenged by this diagnosis. They're still missing it. Because if you look at the permutations, like if you just had physical symptoms, you're tired, you can't sleep, and you ache, and you don't present necessarily with sadness, you know that you're going to get all kinds of blood work done, you're going to get all kinds of tests done, and then at the end they'll say, you know what, Mrs. Jones, we haven't found anything physical. I want you to go see this guy called Chokka. He's a psychiatrist. Maybe he can help you. And one of the things we're trying to say is, no, let's look at physical and mental in the same plane. And our rule is the more physical symptoms you have that are unexplained, the more likely it's a mental disorder. Our mind and bodies were created as whole beings. And that's the challenge with depression. So what's complicated isn't one thing. It could be many things, but these are the core symptoms that we're looking at. Now, I want to address the question that you asked. What is depression? And this has been an evolution. And depending on what century of life you were born into, it's had different causation. It's gone from witchcraft, curse of Satan, to blaming your parents, blaming your environment, and so on and so forth. And I think what we're realizing is that there is a combination of factors that are involved in causing depression. And if you look at most medical illnesses, it's the same kind of complex causation of nature and nurture. So for me, your family history is important. If it's carrying in your family, you're at a higher risk. However, we also have incredible individual factors. Some of us are just a lot more resilient and stronger than others in terms of our temperament. And so you can take somebody who's at risk and put them in a bad environment, and they've come out relatively unscathed. And that, to me, is what my normal outcome is. I have been so blown away at how strong mankind is, how resilient we are despite bad things happening to us, despite bad environments, despite trauma, despite physical illness. Our rule is not post-traumatic stress disorder. Our rule is post-traumatic growth. That's how we're wired. Most of us come out of this stuff fairly strong. But we know that in some individuals, having a genetic risk, having some form of trauma, and the earlier the trauma is, the more difficult it is for you to overcome. And that's because as you grow older, your brain starts to adapt better, you have better ability to understand yourself and the environment. But when you're a child who's being sexually abused or physically abused, we know that puts you at a risk. We know that losing a loved one before the age of about 10 or 12, especially a first degree, like a mom or a dad, and you have a risk of depression, puts you at a higher risk. We also know that there are certain conditions that put you at a higher risk. So for example, if you're a child who's a nervous willy wart, always concerned about bad things happening, we know that kids who are anxious are more likely to become depressed. And so there are some environmental factors. We also know there's what I call cognitive factors. There are some kids that are just wired from the get-go of looking at the world negatively. Do you have any of those kids? No? You guys are good kids? Everybody's fine? I got 3 kids. Same genetic pool, but they're very different. And I knew that from the time that they were born. You can just see the differences. And now they're into their early 20s, mid-20s, and you can see those temperaments fairly consistent. Yeah? You know who your anxious kid is. You know who your difficult kid is. They kind of get better, sort of, but you can see early on. And we know that certain temperaments are more prone to having these conditions. It's that whole biology, nature, nurture coming together. What I think is really cool is that we can intervene early, not with medications, but certain types of talking therapies, which we'll talk about. But we also know that with your environment, with losses, with temperaments, this affects your brain chemistry. We can actually induce depression clinically. I can deplete your serotonin in an environment setting, and I could make you sad very easily. I could make you very happy easily too. Right? So there's chemistry involved in this, but it isn't just a chemical disorder. And we know that you've got the brain chemistry, but then you have all these circuits. Think of this as electrical circuits. And different parts of the brain are communicating, but we're finding that the communication between the emotional parts of the brain, the logical parts of the brain, it's like they're broken. It's like ground under repair. And one of the cool things is we're trying to connect these broken highways. And we know from beautiful studies that the front part of the brain is very underactive in depression. The logical, that makes sense, is not. The emotional, deep emotional part is lighting up like a Christmas tree. It's overactive. It's oversensitive. And so what we know with treatment is that we can connect the front part with the emotional part and deep in the brain and restore some sort of semblance of logic to make sense of what's happening. What we also know, unfortunately, is that if you don't treat depression, your brain actually starts to die. Did you know that? Depression is like Alzheimer's. It seems to cause brain death, cell death. It's actually as if your brain's on fire. And we now have studies to show that the cells of the brain are shrinking or dying, especially in the areas of the brain that deal with memory, called the hippocampus. And the longer one goes without treating it, the more difficult it is to bring back that broken brain. And that's why it's really important early on to get people assessed and treated. And so it's this complicated nature and nurture coming together. It isn't just one factor. It isn't just one disease. And that's why one treatment doesn't fit all. And that's where it's getting complicated, because we don't have a blood test. I'd love for you to come into my office and I'll say, you know what, this is the kind of depression you got, and I got a treatment just for you. We don't have that yet, because we're dealing with the brain. We're not dealing with, I don't know, I shouldn't say like the kidney, although it's important, right? It's what makes us human, is the brain, and it isn't that easy to figure out because we can't just probe it. And that's where the challenge lies. We're beginning to see that there's different aspects of depression. You may have more of the memory issues, and we're beginning to identify that. You may have more of the mood issues for depression, and some will have more of the physical symptoms. So we're beginning to look at the different domains of depression, because maybe if we can understand it better, then we can have better treatments, you know? So that's where we're going to. It's kind of exciting. Now, in terms of treatments for depression, I'd love to say that we've come a long way, but I think we're struggling with it. I think that there are treatments that are available, and I think we have to be very selective of the type of treatment you get. I want to tell you that I think people out there think that all doctors do is marinate people with drugs. And I think sometimes that's true. But I will tell you that if you have moderate to severe depression, it's really hard to do counseling, because you can't think straight. You can't do the therapies you need to figure things out when your brain is so broken that you can't focus, you can't concentrate. Believe me, I tried doing this, and they won't remember the next session. They don't remember what we talked about. And it just is trying to run on a broken leg. You got to let it kind of heal and set before you can do things. It's the same thing with the brain. It's all about timing and giving you the right treatments. In mild depression, it seems like anything can work. Prayer, eating right, standing on your head and drinking water, like it doesn't seem to matter. It all works. In severe depression, moderate depression, medications are probably the first go. That's only the beginning. Because a lot of times you need to address this stinking thinking. And that's the start, because you begin to develop what are called distortions, cognitive distortions. So it would be things like devaluing the positive things. It would be emphasizing the negative things. It would be discounting all the good things that have happened to you and looking at the world as half empty. And cognitive behavioral therapy addresses the thought patterns that you have. Now, all of us have stinking thinking. It's just being human. The gateway to knowing that your thoughts are distorted is through your emotions. So when you feel irritable, agitated, angry, sad, depressed, that's your signal that whatever you were thinking about an event needs to be reflected upon. Because our thoughts are so fast, so unconscious that you can't have access to it, but your emotions are the gateway to it. The problem is, most of the time we go and jump to conclusions about the negative aspects of it. So cognitive therapy addresses that, because we tend to be, and depressed patients tend to be very reactive and not reflective. And so if we can actually slow that pattern between a thought, which is unconscious and fast, to an emotional state and reflect on it, we can actually start to change things. And it's really interesting. Just like medications have been shown to change the brain, we know that therapy can change the brain. And those really underactive areas are beginning to light up and get more active with therapy. And that whole hyperactive part of the brain that's really emotional starts to cool down. It's really remarkable that you can make changes not just with one type of approach. We know that exercise is a huge component of well-being, especially as an add-on to treatment. We know that prayer, attending church, having friendships, having supports are huge. We know, according to the World Health Organization, after diet and exercise, volunteering is a health recommendation. Did you know that? It's so, we were wired to connect with each other. But diseases like depression prevent you from connecting because you're ashamed of what you are. You're afraid to be out there. And so, counseling, medications, socializing, exercising, spirituality, nutrition have all been shown to be very effective as add-on. I also want to say that sometimes, because as humans we have conditions that are very difficult to treat and sometimes untreatable. We all will die. We all will die. And we will die of diseases that are incurable at times, at least the way we have it now. But there are some treatments that actually bring people with severe depression back to life. And I got to tell you, I work at the Grey Nuns Hospital, and of course, as working in a hospital, you see some of the more ill patients. I want to make a shout out for a treatment called electroconvulsive therapy or shock therapy. Now, that may be shocking to you guys that we're still using it today. But I got to tell you, if I'm not getting better, guys, hook me up to that machine. Put me under and give me shock therapy. I tell that to my kids. I tell that to my colleagues. And if this was my daughter or my son or my mother who were depressed or weren't getting better, there's hope. And it sounds barbaric. It sounds like it's things we've done back in the old ages, but I have seen so many lives be changed by this. My oldest patient that I did shock treatment was a 92-year-old lady. She had stopped eating and drinking. She was in a fetal position. She was going to die. And the depression had taken over her. And I remember her, we were worried about her health, and we actually had the cardiology people right next to us. But we started doing the shock treatment, and it's remarkable. By that afternoon, I saw her kind of give me a little bit of a smile. It's remarkable. There are some treatments that work when pills don't work, and I want to tell you that. Support groups, self-management. So there's a lot of options, and we can talk a bit about that. What we want to do is restore function and quality of life. That's what we want to do with depression. But there's lots of barriers. There's lots of barriers to this. There's stigma, looking at depression as one disease, focusing on symptoms and functioning. We're still having a heck of a time diagnosing this thing. And one of the things we're telling doctors is, in addition to talking to patient, there are some instruments you can do, scales to combine with your talking that will increase the likelihood of a better diagnosis. This diagnosis is often missed. So we're telling physicians to use some tools. The challenge we're having is we're having access to affordable treatments. In Canada, you can go see doctors as many times as you want. And I don't think that's right, because you can't see your psychologist or your counselor as much as you want. And I'm telling you, those are very effective treatments. And I can't understand that. And we have compelling evidence that counseling makes a huge difference along with medications. The other thing we have is that we don't work together as teams in dealing with patients. We deal in silos. We just compartmentalize. One of the things that has been a blessing for me over the last several years is, and Pastor Murley talked about our center. It's an attempt to kind of bring together different practitioners who have same values, but they're not just physicians. They're psychologists, they're family doctors, they're psychiatric nurses, and I actually had a naturopath there. I can't believe I said that. I had a naturopath at our clinic. I mean, 25 years ago, I'd have thought, are you crazy? But that's changing now. We have specialists who view things differently and come together. We need to have evidence-based and science-based, because I think there's a lot of quacks out there. And I say that with legitimacy, who are trying to make this into a merchandising enterprise, who will hang up a shingle, who will sell their herbs and dupe individuals to thinking that this is going to work for them. There's the charlatans out there. And I'm not saying amongst our fields there aren't good physicians or bad physicians. I'm not saying that. But somehow in this cottage industry out there, there's people who can hang up. I was driving by the White Mud, and on the grassy knoll there, they said free counseling. You know, it's one of those little things in the lawn, free counseling call. I just thought, oh my gosh, you know, it's dangerous. Counseling can be very dangerous. Not just anybody can do this stuff. But I think we think that we just go and talk and it's all okay. No, first do no harm. Got to be careful. And that's why I think we need to be serious about the kind of help we get. Because there's lots of misinformation about this. And I'm sure you've got people come to you and go, you know what, I have found this herbal product. This is going to change your destiny. And you have to pay $400 a month. And you have to get off your antidepressants before you can try this. And I know that you guys have come to me with this. And I'm not saying we have the market on this in medicine, but we got to be careful. And we got to work together on this as well. And so in the future, I think things are going to be a bit different, hopefully. And this is a bit of a fancy slide, but it'd be neat to be able to take your blood or your genes and say, this is the type of depression you have. And then we can have specific treatments. It's kind of like what we do with cancer, right? There's markers in cancer. We know there's certain types of breast cancers that have certain markers. And we know that if you have this marker, you're going to be better with this treatment. That's where we want to be able to go to, instead of a shotgun approach. Now, it's not as blind as it seems, but we want to get more specific. We want to look at the symptoms. We want to look at the patient profile, right? We want to look at your environmental factors and come up with a holistic approach to your diagnosis and treatment. And then once we have an accurate diagnosis, we can have targeted treatments. That's where we're missing right now. We don't quite know if this particular treatment fits you, right? And we all heard stories where, you know, I'm sure they'll say to you, you know what? Cipralex, that was a great drug for me. You should try it. And you try it and it doesn't work for you, right? I see this all the time. We're struggling with trying to find combinations that work for individuals, but there's hope. And I think there's hope because there's good research going on. Patients are dedicating, you know, we do research at our center, and I'm just blown away how patients are willing to go into clinical trials to help not only themselves, but help us to understand this disease better. Kudos, right? So that's kind of exciting. We're making some breakthroughs, but I think we have a long way to go in that. I want to tell you that this illness is now something that has been recognized around the world. I told you that it was a disabling disease. Just a few weeks ago, the World Health Organization had World Depression Day. I couldn't have imagined this decades ago. So wherever you are, and there's really cool posters, whether you're in sub-Saharan Africa or India or Canada or whatever, it was World Depression Day. And they had all these posters about let's talk and let's get out there so that people who are suffering, whether it's young people, older people, pregnant moms, so on, can talk about this so they can come and get help. So one of the things I wanted to do today was to talk about this illness. And I hope that I've shed some light on it. And I really want to now in the next few minutes open it up for questions, now that we've kind of set the tone so we can get a little bit more practical. But I wanted to kind of give you a bird's eye view on this, and you guys have been a very good audience. I don't see anybody falling asleep yet, you know, and you're awake. And I know the Oilers game is starting very soon, so you probably want to go there too. How's that? Hey, yeah, I see heads nodding. Yes, yes. But let's first of all, thank you so much for being a great audience. Okay, listening to me, And let's open it up for questions, okay?
Okay, we have actually a couple of different microphones we're going to be operating, and so we want everyone to hear your question. So Pastor Kern is going to have a mic there, but in the meantime, I will come over here, and I saw 2 hands go up over here, so here's your question.
Can you tell me how depression and anxiety are related?
Okay. So, when I talk about depression not being one condition, I think that's a good example of that. Anxiety occurs in about 70% of patients with depression. And anxiety begets depression, and depression begets anxiety. And when we look at the brain chemistry of these conditions, there's so much more overlap than dissimilarities. Okay? The symptoms of anxiety are often broken down into physical symptoms and psychological symptoms. All right? So, yes, they're related, they're very common, and they overlap. But they have some distinct differences. The treatments are a bit different, although there's similarities. All right? Physical anxiety will often look like this: tense, keyed up, on edge, tight shoulders, tight neck muscles. You can have problems with bowel, diarrhea, constipation. Irritable bowel often is one of the big things we see with anxiety. You can always sometimes feel like this tingling in your fingertips. You may have this chest tightness. You may have your heart racing. Okay? That's some of the physical symptoms. It often is also accompanied by psychological anxiety, which is worry. It's this uncontrollable fear, and what I call what if. And it's like you live in the world of what if. It's 5:05. My husband said he's coming at 5. He must be in a bad accident. Something bad's happened to him. You begin to worry. You begin to have this sort of sense of something bad happening to you that often is accompanied by sleep problems. Okay? And so you can see how some of those symptoms, but there's a look about anxiety that's different than depression. It's this sort of, and I see this, they're often in the edge of their chairs when they're in my office. They're wringing their hands. They've got this pensive look, right? See, a bit of anxiety is there for us to do, to attend to what we need to. We need anxiety to kind of accomplish things. But when it overwhelms us, it debilitates us. So to answer your question, they're common, there's overlapping, similar treatments, but there's also different treatments that go with it.
Okay, I saw another hand right here.
My question is, are you taking new patients?
Well, you bring up a great point. My whole afternoon I was doing a clinic. I've been doing this for 25 years, and I have developed amazing relationships. I'm going to get to your answer right away, but I got to give you a preamble. One of the problems in psychiatry is, unlike other specialties, we were trained to see patients and continue to see patients. Cardiologists don't do that. Neurologists don't do that. If you go to a cardiologist, you're going to follow up with him or her? No. But psychiatrists have done that. And one of the problems, I think, is that we have not referred the patient back to their primary care doctor. And what happened to me over the years is you get so full with patients because you do assessments and follow-ups. And you can't see new patients because then you have a collection of patients that you're following up, but you can't do new assessments. So we're trying to do something unique at the center because we share care. So yes, we do take patients to the Chokka Center. We're trying to come up with ways of addressing the need of the long wait lists. The average psychiatrist to see is about 4 to 6 months, which is unacceptable, right? In Canada, it's crazy. I mean, part of it is you can't see a psychiatrist unless you get a referral, which I think is inappropriate anymore. In the old days, family doctors were gatekeepers, but I don't think we need that anymore. But that's a whole other system issue. And I think we need to share care our patients with this illness. Educate our family doctors better. It's not a sexy condition for family doctors to really address sometimes, right? But, so yes, we are taking patients, but there is an issue with the lineup to get there. Other questions?
Question right here.
Yeah?
You were asking about different things we had heard about depression. I've heard that there was stats they're putting together that in Alberta, with our Chinooks, our highs and lows that are quite dramatic, that it also impacts depression.
Yeah, I mean, the literature on temperature and depression is poor, but there is some good literature on sunlight and depression. So seasonal affective disorder, maybe that's what you're referring to more than temperature changes per se. I haven't seen that on temperature, but we know that in our climates, and this last few years, boy, with the global warming, it's warm, but it's more cloudy than ever, right? Mm-hmm. Have you noticed that? Mm-hmm. And we're noticing that there's more rates of depression associated with decreased sunlight. And that's why, especially in Alberta, go to Costco and get the light box. It's $150, I think. And for those of you who have seasonal mood changes, maybe not even depression, stick your face in front of it, not directly, but just kind of close to it. 30 minutes, once or twice a day, really elevates your mood. All right? So there's some good treatment with light. So I think it's more to do with...
It just cost me $150.
Oh, did I? It's relatively affordable antidepressant treatment. You can get some potential side effects, but it's really an effective treatment for seasonal affective disorder. Questions? Comments? Yes?
How can we visit people with depression or conduct ourselves around them? We can't bring them out of depression, but what can we do with them, for them? Thank you.
Yeah, that's a really good question, because it's a little bit like I find sometimes just listening to them, providing them a support, maybe doing things. I think we often get into help mode by giving them advice. And I'm not saying we shouldn't do that, but I find that depending on their state, it's difficult for them because they kind of know it. We all kind of know it. We know we should eat better. We all know we should exercise, right? How many of us do that? Like, we know it, right? But it's really hard until we get to a point where we're motivated and we can make the changes. So I think listening to them, being there for them by being present with them instead of avoiding them. I think you can also talk about things that are difficult and not worry that they're going to go and kill themselves. This is one of the big stigmas that we had to dispel, is that if you talked about suicide or asking patients about suicide, that they're going to go and do it. It's not true. And so I think being real with them, I think, is also something that's very important. I think acceptance of them is also really important, because I think there's such, like, one of the biggest symptoms that's so difficult to treat is guilt and self-blame and self-loathing. And I think by just you being there, by listening to them and providing that support, I think there's a self-affirmation that comes with that. I think directing them to get help is also important if they don't see that. Because I find when I talk to patients, I'll say, why did it take so long for you to get help? And a lot of it is they're trying to sort out why they feel the way they do. And they're trying to make sense. Well, maybe it's my wife or my husband, it's my job, it's this and this and this. And there's so many attributions when we feel so miserable as to why we feel miserable. But maybe after tonight, you will have a different idea of what depression is and say, you know what? There's this thing called depression. I went to a seminar the other day, and it's a brain condition, I heard, This isn't just about how bad things are for you and so on. And I heard there's real help for this. Are you interested in that? Because I don't think we see this as a medical problem sometimes. And that's a problem. And we often medicate ourselves with alcohol and drugs. I haven't even talked about that today. I've stopped looking at addictions differently than what I was taught in medical school. I was taught when anybody came with alcohol or drug abuse, you direct them to ADAC, you direct them to the George Spady Center, and then you come back and get help. If I told all my patients who have addictions to go get help before they come see me, I don't think I'll have many patients left. Addictions are the way that we treat our misery. And if you can treat the underlying misery, the addictions really start to fall off. And so have compassion on those that are suffering from alcoholism, or cocaine abuse, or cannabis use, instead of, I guess, scolding them necessarily. I'm not saying that you just accept it. But if you can look at the person behind their behaviors, I think that's much more helpful. And not get caught up on their behaviors, which is what we tend to do. Behaviors are a very crude measure of the heart. They don't work that good in measuring what the heart's like, because we can fool ourselves and others with behaviors. Yes?
I think there is a few issues about this depression thing. The first is that it's very difficult to access the professional to get help for this, because it's very expensive, first of all, and also there is not, enough doctors to help with this. That's one thing. But the other thing I would also like to ask about, it's about the fact that even when you access the professional, my experience, because I'm doing anthropology at University of Alberta, one thing that I saw, and I discussed it also with some professionals, is that in a very diverse country like this, some patients that come to you don't always really have the support or answers that they expect from a professional. Maybe because, there is really a kind of cultural barrier or challenges that the professional don't always, are not always very familiar to. So there is things like that. And I was wondering if you can speak about that, if you can tell us something about these aspects of the depression. Because when I see, for instance, I'm doing some research, discussing with men, women, and issues that arise in the families of immigrants most of the time. So there is a lot of things that I'm not a professional, but that looks a little bit like what you're talking about right there, happening in the family. So, but the access to the professional is difficult. So how do you...
Right. So like I said earlier, access to family doctors is generally easier. Would you agree? But the challenge you get is that even within our own field, I think there's stigma among medical professions about mental illness. And there are some primary care physicians who will dismiss it very easily and not take the time, because this isn't as quick as doing a blood pressure or opening your mouth to see you've got a sore throat. It takes time. And family physicians especially have the burden of time management. There's overhead and so on. And I can't, I'll tell you what, being a family doctor is one of the toughest specialties, because you got to know something about everything, right? Or something, you have to know a little bit about a lot of different things. And so you hope that you have a physician, a family physician, who is open to these kind of illnesses and has an understanding of it and takes the time to talk to you about it. I think you as patients have every right to challenge, question your family doctors. find somebody who is a fit with you. I know it isn't that easy to speak up to professionals, but you have that right. You should use it. I would start with that. Find a fit. The next layer of access to psychiatrists, if you do need it, is challenging. But 80% of patients with mental health issues are seen, assessed, and treated by family doctors. So the majority of people with depression go through family doctors and get treated and do actually not a bad job of doing it. We tend to see the more difficult to treat, the more complicated ones. And unfortunately, because of all the things I've said to you with depression, there's no easy treatments. We tend to see these complex cases. But there's so many complex cases that our waiting times are long. The access to psychologists is the other issue, and therapists, because most insurance plans, most employers don't have benefits to go and see counseling. If it is, it's very minimal, right? Average, you need about 6 sessions to 8 sessions. Registered psychologists in Alberta are $180 per hour. Sounds like a lot, but they're trained professionals who've gone to school and have worked hard. But access to their services because of financial problems is a barrier. Now, I know in Edmonton, there's what's called the primary care networks, where you go to your family doctor, and the government of Alberta has some counselors that they've set up at certain clinics. There's certain programs at certain clinics. There's also free services through what's called the Alberta Mental Health Services in Edmonton. There's various areas in town that you can actually literally pick up the phone and call. I used to work 18 years at the downtown office on 108th Street, but there's one at the Northeast Center, there's one in Sherwood Park, there's one in Leduc, there's some in Spruce Grove. So there are some government-based clinics. The problem is people aren't aware of it, and neither are the physicians, like the family doctors, are aware of it. So we probably need some more larger education, advertisements and so on, so that people would know that there is help out there that isn't always cost prohibitive. There are some free access. But I agree with you, the barriers are there for care. As I said, there's the stigma barrier, there's the financial barrier, there's the access barrier. And I think this is why, if you look at what Justin Trudeau has been trying to do, is make mental health a major issue for the Liberal Party. And there's this push in Canadian health to talk about mental illness a lot more than it used to be. And I think we're going to see the consequences down the road. And it's the kind of things that Pastor Murley and this church is doing in trying to bring it out. Because I know that what you heard tonight, you're going to go tell somebody else. And that's going to make a difference. Mm-hmm. So I think there's hope. Sure. But there are certain barriers that we're still having to get through. I think the biggest barrier is ourselves first. Mm-hmm. Mm-hmm. And once we get there, I think we can move the
Dr. Chokka, a quick question for you. Many of us have family members, friends who are suffering from depression. Are there specific danger signals that we should be alerted to, that if we are seeing in family or friends, that we take steps to get them the help, even though they may not be agreeable to those steps?
Okay, so that takes it to another level.
Yes, it does.
Right?
Yeah.
Because, so it comes down to competency and dangerousness. So, and this is where it's a minefield from a physician's perspective, is somebody competent to make decisions? And competency, in the largest definition, is an awareness that you have an illness, that you can talk about your illness, the treatments, and access and taking of treatments, and you can make informed decisions. That's competency. However, you have individuals with depression whose lines are crossed to where they're not competent to make decisions. And that is where it gets a little bit dicey. And so when they're talking about a risk to themselves, when they're talking about suicide, when there's a plan, when there's a means, a method, you take that very seriously. And I wish we were better at predicting suicide or predicting harm, but we struggle with it. I tend to be more proactive, and I'd rather err on the side of caution. The government of Alberta allows me, as a physician, to literally declare somebody not competent to make decisions. There's legislation in peace that says that if you have a mental illness, that you're a danger to yourself or others, you need to be in a hospital, that we have legislation that can do that. Now you as a lay person would have to probably, A, go to a judge. Okay, it's called a magistrate's warrant. Okay, and basically you go to a judge and say, my family member has a serious mental health problem. They're not taking their medications. They're talking about suicide or psychotic symptoms. The judge will listen to your story. The judge will either give it to you or not. If they do give you a warrant, the police can literally come, apprehend that individual, and take him to the emergency department of a hospital. That doesn't mean they're going to get admitted, but they will have an assessment by a specialist. So that is what you as family members can do when you've exhausted logic and goodwill and motivation, and you are so frightened by the outcomes. So you literally have to invoke legislation, all right? And there's it's a form that you fill out, you go in front of a judge, and they will give you that. And at that time, that's where the judge will have to make a decision, right? Is this family member coming in good faith, or do they want to do harm to this person? Because that's the other side of this. You know, if you don't like your neighbor, you know, you can make stuff up, right? The challenge in our country is we will err on the side of caution. And so there are people who need to be in hospitals or are not in hospitals. Because in 40, 50 years ago, people were in hospitals who shouldn't have been there. So we've swung the other way. And it's frustrating for families. I know that. I've been there, defending, trying. But there's also legislation that protects us too, so that individuals who've taken away our rights inappropriately don't do that again. So that's, in short, an answer.
Good, thank you.
Yes.
I'm currently dealing with a gentleman who is no relation, who has clinical depression. He doesn't talk about suicide, but he's trying to commit suicide by not addressing the physical ailments that he has. If I can get him in an ambulance and into a hospital, how much right do I have to go to his doctor and tell him, you need to keep him here, you need to treat these physical ailments, not only the ones that he came here with, but the ones that he keeps canceling appointments so he doesn't have to deal with them. Do I have any rights?
Well, you have a right to tell the doctor what your impressions are. You absolutely have that right. The challenge will be with what this other individual will tell the doctor. And the doctor then takes this information. That's what we do all the time. You know, and this is a big part of the assessment piece, is listening to the patient, but I really find it valuable to talk to the family members. Because as I said, they don't sometimes perceive things the way they ought to. But it becomes a really dicey situation if he presents himself as being kind of put together and he says, you know I have this, but I don't really want to get help. The doctor really, we're kind of handcuffed. And so unless he's really mentally unwell and incompetent, you may not be fortunate. You have the right to tell the doctors. We will listen to the family members. But that individual in front of us is, because confidentiality is the number one thing with us. We don't ever want to break that, because then everything falls apart if my patient doesn't believe that I've had their interests and not looking out for you. So it's complicated. I know it's frustrating because you know that things could change, but it's called choices. And ultimately, That's what it comes down to, unless he doesn't have the right mind or the capacity to make those choices. But yeah, go ahead. It'll help in the long run, perhaps.
You've spoken about the correlation between mind, body, and spirit.
Yes.
And I appreciate you sharing that. Can you comment on how important a good exercise, good food, good, sunshine, the more holistic?
Oh yeah, absolutely.
Yeah.
This is what's kind of exciting in my field, is that we're looking into areas that I don't think we did as much. So I can start with exercise. There is a plethora of data that exercise of any kind, whether it's aerobic, anaerobic, whether it's 5 minutes or 50 minutes, helps tremendously. And there's connections to the brain when you exercise that improve serotonin level, dopamine, which is this wonderful neurotransmitter that makes us feel good. It's the kind of neurotransmitter that if you won the lottery would be just like skyrocketing, but exercise really seems to make a huge difference. What I tell people with exercise is, if you haven't been doing anything, forget about this 30-minute piece. 30 minutes 3 to 5 times a week, forget that. Because with depression, just getting out of bed is a chore. So I try to make it very minimal. Like I say, give me 5 minutes of walking. Just start with that. For those of you that are exercise fiends, that's nothing. But if you suffer from depression, it's heroic. And to me, it's about starting a pattern every day. And walking is the best way, or swimming. But walking is, even when you're depressed, you can at least do that. But it's daily activity that seems to be really quite important. Nutrition. Very little literature has been done on nutrition and depression. We know that certain foods don't make us feel good. So there was this wonderful study on the Mediterranean diet in Spain. So Mediterranean diet predominantly is vegetables, legumes, nuts, the Spanish Mediterranean diet. And they looked at university kids in Spain, and all they had to do was check off the foods that they're eating. And they followed over 10,000 Spaniards for 4 years. And what they found was these young university students who stuck to a Mediterranean diet, which is, predominantly less meat, more fish, nuts, legumes, their risk of depression was about 4 times less than those individuals who didn't adhere to the Mediterranean diet. Now, you've heard of the Mediterranean diet. It's great for the heart, right? And we know what's good for the brain is good for the heart, and what's good for the heart is good for the brain. And we know, for example, like if you ever, are you guys familiar with the blue zones?
Mm-hmm.
Yeah, have you heard of this? Dan Buettner in National Geographic looked at societies around the world that have the oldest living people. You heard of this? It's amazing. And they're in disparate parts of the world. There's Okinawa, Japan. There's the Nicoya Peninsula in Costa Rica. There are the Seventh-day Adventists of Southern California. There's the Sardinians out of Italy. And it's fascinating how diet played a huge role in longevity with all of these individuals. And not only were they living longer, but their brains were better. All right? So nutrition is really important. And again, there's so many things out there about nutrition, but to me, a lot of it is about vegetable, plant-based. If you're going to eat meat, small portions. The brighter the color of your fruits, the vegetables, the better they are. The antioxidants, the omega-3 fatty acids and stuff are really good. I think attitude about what you eat is also important. If you're eating healthy but you're miserable, I don't think that's good either. Right? In fact, they've shown that. They've actually shown that. Do I have time for a quick story?
Sure.
Oh, this is fascinating. So they looked at cholesterol in rabbits, okay? And this is really interesting because in this particular study, they're looking at how rabbits and cholesterol, they were studying cholesterol. And so they were feeding these rabbits like bad food, cholesterol foods, okay? And so they noticed that, the majority of these rabbits who were fed cholesterol wound up having bad cholesterol. Makes sense. But then they found this one group of rabbits who were fed the same bad cholesterol, but their cholesterol, when they measured it, was actually normal to less than normal. And the scientists were blown away by this. How is it that you've got 9 groups of rabbits, you feed them bad stuff, they got bad cholesterol, and you got this one group, and they don't have bad cholesterol? And they were perplexed for it. Maybe it's their genetics. Maybe it was their environment, whatever. Well, they couldn't figure it out. Do you know what it came down to? What did it come down to? It's fascinating. The one group of rabbits whose cholesterol was actually normal to lower, they found that the research assistant who was feeding these rabbits, instead of feeding the food through the cages, would take the rabbits out, play with them, and feed them. So, as important as our diet is, it's our attitude about what we eat. God's given us a mind and a brain to take bad things to make them good. And that's really as important as the exercise. Because I think if you're miserable about what you do, I don't think that's good. It won't be good. So your attitude about exercise, nutrition. The other thing is about relationships. One of the great studies that was ever done, it's called the Harvard Study of Adult Development. It started in 1938, and it's still going on. It's an amazing study. And they were looking at what makes a good life. And millions of dollars have been spent on this, but it came down to relationships as being seminal to well-being. We were wired to connect, and we actually have, in our brains, we have this connection. And when we have good relationships, and it's not the quantity of relationships, this Facebook thing about numbers doesn't work. We're more lonelier now than ever. That's why, going back to your question, what can I do? It's just being a good friend and being supportive, touching each other in emotional ways and spiritual ways, having somebody who really gets you. And when somebody gets you, you feel good. You feel understood. And if we can nurture those relationships, that seems to go a long way for better outcomes in health. In fact, in this study, men at 85 who did really well, the one single factor that looked at well-being at 85 in these men, because it was the Harvard study was done in the 1930s and only men were studied back then, all right? And what they found was, independent of any of their medical things like cholesterol, high blood pressure, men who checked at the age of 55 that they had a wonderful, stable, loving relationships, that was the single determinant of well-being at the age of 85. Their brains were actually functioning better. Their bodies were functioning better. Not their cholesterol readings, not their high blood pressure and all that. It's having a nurturing, caring relationship in their mid-50s left a great mark in their 80s. Now, for those of us that have broken hearts, broken relationships, it's never too late to cultivate loving kindness, because that is really good for our health as well. It sounds hairy-fairy, but science is catching up. The other thing we know is attending church, spiritual. This is one of the most robust findings in psychiatry, is belonging to an organization, a church organization, believing that there's something greater than what we have here. Now, I know I sound preachy, but science is supporting this. And there's actually a whole branch of science called contemplative neurosciences, where religion and spirituality are now being looked at. There's probably something that we're wired to be this way. There's no doubt. And if we can cultivate that, spirituality, it's really important. There's a difference between religion and spirituality. Do you want me to tell you? I've heard this is a great definition. Religion is for people who are afraid to go to hell. Spirituality is for people who've already been there. And if we can find that, it seems to also really make a difference. And that's why chaplains in the hospitals are such a big part of treating patients with depression. The spiritual aspect of it, visiting people, These were people who would be in the back wards of hospitals 60 years ago, in asylums, right? And The cruelest punishment that we can ever do to anybody is put them in isolation like we do with our prisoners. They say that's the worst form of treatment is those isolation cells, because we weren't wired to be that way. So those are some of the other things that I think we can do.
Good. Okay, are there any further questions? It's 25 minutes to 9, believe it or not.
There's one,
And Dr. Chokka has been such a great presenter for us. Here you go.
Yeah, I can help asking what to do with youth, because there are this problem. Youth are are facing seriously depression problems.
Yeah.
So, and we have children, just like you.
Yeah.
So what can we really
So
do to help this?
I really think the next big wave, and we don't talk about this, but this is a passion, and hopefully in my next remaining years, is we're going to have to talk about prevention of mental illness. And there's different types of prevention. I mean, it's always going to be with us. But I think we are now looking, there's actually some interesting work looking at-risk kids, that if we intervene early with at-risk kids, we actually seem to decrease the onset of depression, and if they get it, they get less severe forms of it. So it's taking children of at-risk family members and making them aware that early on, this is the kind of things that kids that are depressed look like. That there's a difference between depression and sadness or just home stress. We need to more educate our teachers. But I think the biggest thing is educating parents to recognize what conditions like depression look like. Because I think, unlike physical illness, we will tend to ignore the psychological aspects of our children's health. Most of the time we delay it. Whereas if it was physical, we are rushing our kids to see our pediatrician. But we don't do that because there's still the stigma of seeing a psychiatrist or a psychologist. So I think if we educate family members, and I think forums like this, Bell Canada's Let's Talk, are really important. And maybe tonight you'll go and talk to some of your own children about what's going on. It's so difficult because at that stage, kids, they don't care about anything. They don't care about their physical health. They don't care about their mental health. They're just being kids. They don't recognize it as a problem, right? So a lot of it is forming relationships with your children so you can have open communication, transparent communication that isn't judgmental. Because oftentimes this comes on the heels of some kind of event that's been bad. They failed a class, they got suspended, they got caught drinking, and we focus on their behaviors. And I'm always curious about what's driving their behaviors. And so if you can create a home environment where it's comfortable to talk about things, that would be the start. So that's where it starts for me, is in the home. And then we can do the layers from there. There's like tons of layers, right? I think much like, I got to give you an example. I grew up in Alberta, like I said. In the early 1970s, this drinking and driving thing was, I knew people would drink and drive. It was normal. You'd never wear seatbelts, right? And smoking, everybody smoked. But we've done some real good campaigns that it's important to wear seatbelts. We know now that drinking and driving is not cool. The cigarette smoking in kids is coming down. So there are public campaigns that I think we've done. I think we need more of these serious government-led initiatives from larger talking about mental illness. We see some of the commercials. I also think the commercials should be more fun, and not so down and dreary. The one, have you seen the black dog video from the World Health Organization? It's really compelling. So there are agencies throughout the planet that are looking at this, but if you want to YouTube it, you'll see them talking about the black dog, which is depression. But introducing this in our children, in our schools, early on, getting them to, it's called reading, writing, and reflection instead of reacting. So in Southern California, in some school systems, this whole idea of meditation, and I know in certain church, contemporary Christian world, meditation is with Eastern philosophies and Buddhism, and no, it's really just about being present and praying or meditating paying attention to what's going on now because we're in such a distractible world. So that's the kind of stuff we can intervene at the school level, education, you know. And so I think from there we can move on to larger initiatives, is the way I see it. That's a whole public forum discussion. But I think that's where it goes. Thanks.
Great. Well, almost 8:40. Dr. Chokka, I would just like to thank you on behalf of our board here and the church, because I think we have done something extremely important, and that we've opened a dialogue. And it's my personal belief that we need to be talking about these issues. Many years ago, the thing was it was hidden, it was pushed aside. And mental health and depression oftentimes were taboo subjects that, you know, well, there's something wrong with him, he's not quite right, but that was always said. Mm-hmm. And I think that one of the most important things that we can do as a community is to dialogue within our own families, as you've said, with other community stakeholders. And we need to push for the changes within our medical system that needs to happen so that we can provide the correct, treatment plan for each individual person. And we recognize the issues that are there. So, you know, take from this knowledge and use the knowledge that you've gained tonight to continue to share, continue to dialogue and have this discussion, because it is a vital discussion to have within, first of all, families, within your church relationships, within the community. This is a serious, serious problem that we're facing. And the Let's Talk really helps. But if all we're going to do is send a text message on April 7th, then that's not very much, is it? We need to have the conversation. So that's why I appreciate you coming tonight. And I would really like to thank Dr. Chokka. He's been a wonderful presenter, beyond my wildest dreams. And I just know now why you are held in such high esteem within the city of Edmonton and around the world. So can we bless you? All right.
I need it. Thank you.
All right. Lord, as we leave here tonight, we pray that you would bless Dr. Chokka and his ministry. And his ministry, Lord, is working with those who are dealing with some of the issues that we've talked about tonight. Continue to give him wisdom. Continue to give him a voice to speak to the community. And just pray your blessing upon his center and the work that he does with the patients. To your honor and to your glory, we pray in Christ's name. Amen.
Thank you.
Hey, if you're with us, we want to remind you that on Friday night, the problem that the world is facing today, with all of the suffering and all the pain and all the violence and all of those things, how did we get into this mess? We're going to look at the real reason that we're in the mess we're in Friday night at 7 o'clock, and then on Saturday night at 7 o'clock, we're going to be talking about the real solution to the mess and how we're going to be able to solve the mess that we're in. So we want you to come out Friday night, Saturday night, and join us. And remember, next Wednesday night, maybe get a little bit of stress relief, come out and do some painting. And if you're like me and you can just draw a stick figure, that's fine, okay? But just come out and enjoy it and have fun. Invite your friends. We have lots of supplies for everyone. So thank you for coming. Good night. God bless each one of you.